Hello, I'm Keith Swanson. I'm a faculty member at the University of Oklahoma College of Pharmacy. We're here at the Fountains of Canterbury today where we're talking about a pain management program that can be implemented to benefit the individuals you care for in your own facilities. I work with a team of family medicine physicians where we take a team approach in integrating the expertise of all on the team so that the patients can benefit and the residents that living here can benefit from everybody's work. Today we're talking about pain control. We'll talk a little bit about the medications, the risks, the benefits, and some of the things that individuals might look for in trying to optimize and increase the benefits of these medications for the residents under your care. I've set a list of objectives that we'll be using during the presentation today. Those objectives span from those related to the actual use of the medications, their risks, their drug interactions, how you assess patients as far as their response to these medications or their need for medications prior to their use, and then how you might integrate these assessments and the use of these medications into your own quality assurance program so that you might meet those quality indicators that we're all judged by outside regulatory agencies. It's with those goals in mind that we'll move ahead this morning. I think all of us know the consequences of pain that we see in the residents that we care for. Those consequences dramatically impact the quality of life for these individuals. They may lead to loss of independence, dependency on others for their care. They might also lead to serious events such as deconditioning, falls, changes in mental status, loss of appetite, weight loss, things like that, and eventually increase the care demands on the staff and the increased cost of care and potential hospitalization or other very negative outcomes that might be experienced by these individuals. One of the biggest things that we look at as we're trying to identify pain is recognize the many different causes of pain. Some of the most common causes of pain include low back pain and arthritis, which individuals have throughout their life. It might be the results of a previous fracture or some other injury. Or it might be due to some of the secondary pains that are caused, for example, the neuropathies that are seen with diabetes and other neurologic disorders. Individuals might also have some different causes of pain that we may not think of that directly relate to some of the care activities and the assessments that we may want to do in taking care of other diseases. Pain may result from just improper positioning or from potentially the use of restraints if those are still being used in your facility. They may result from pressure sores or other types of wounds. They may also result from things like constipation, urinary retention, maybe impaction. Some of those things that we don't recognize that certainly do relate to the care that we're providing to these individuals. Some individuals may have pain from thrombophlebitis or other neuropathy causes. So again, it all relates to the total care that we're providing to these individuals. Due to the prevalence of pain and the effects on patients' quality of life then, it's not unexpected that many of the regulatory agencies that watch over what we do for our residents under our care have focused in on pain. Pain sometimes is called the fifth or sixth vital sign behind blood pressure, heart rate, respiratory rate, and temperature. You could then interpose either pain or weight loss as your fifth and sixth vital sign. So again, it is extremely important that we think about that on a daily basis as we're taking care of these individuals and monitoring their response. Any pain management program should include everything from our recognition of pain, initial assessment as far as both the quantity and quality of that pain, and then putting into place a treatment protocol that includes both medications and non-medication therapies, then the monitoring the response to that treatment protocol, and then finally an adjustment or optimization of that therapy. Unfortunately, what's typically missing from one of these organized pain programs is the key factor of really anticipating and preventing pain. Once that pain happens, it's like once the barn door is open, the horse is already gone. But again, if we can anticipate causes of pain and prevent them, our individuals under our care would be much better off. I think most of us are fully aware of some of the assessment protocols that are out there and available for using for patients in assessing pain. For those residents who are cognitively intact. We've seen numeric rating scales from a 1 to 10 where someone is just simply asked, how is your pain today, with 10 being the worst you can imagine. We might also see some visual analog scales where you see someone pointing to a number on a line, or maybe using the faces scale where an individual can point to, or you can observe someone as far as the type of grimacing or facial changes that you might see. Those are fairly common. We all should recognize that there are also some cognitive scales out there for individuals who are not cognitively intact. One of those, again, you could use the faces scale where an outside observer is then looking at and judging the changes in the facial expressions. There's also a scale called the FLACC scale that's been adapted from the pediatric literature. Again, looking at another patient group that can't necessarily express themselves, but you can look for physical signs of pain. Another one that's very helpful for individuals that have dementia is called the PAIN AD. It's pain assessment in Alzheimer's disease. That scale has a number of different parameters that can be used and monitored by an individual that's been trained to use that scale and can help to assess that level of pain in that individual. So those might be helpful assessment scales that an individual could use and implement in their own practice. Once you've then recognized and assessed that pain, you should also be aware that there's many non-descriptive or directly related to pain symptoms that you could be watching for. These include things such as facial expressions of frowning or grimacing, and some of these have been worked into these pain scales. Sometimes an individual just simply bracing themselves or rubbing a part of their body, or maybe guarding against movement. For example, when someone is maybe dressing or bathing someone, if they avoid being touched in a certain area or avoid moving an arm or a leg in a certain manner, that may indicate pain is going on there. Anytime you see an individual changing their gait, the way they walk, or changes in balance, and certainly maybe falls or other things like that might indicate pain that's ongoing that's not being expressed. And then finally, anyone who has had a change in their level of activity should certainly be assessed for pain that is coming on. Now, our regulatory bodies are now linking parts of the MDS surveys to pain, and some of those characteristics that are noted and documented in our MDS surveys could certainly be expressions of pain if we just look at it with a broader eye. So an individual who is marked with having restlessness or repetitive movements, maybe some sleep cycle disturbances, maybe a sad or apathetic mood, maybe an individual who's resisting care or has some of the behaviors that we often associate with neurologic disorders or dementia, those may be expressions of pain in their subtlest way. It also brings to mind when assessing pain that sometimes if you just ask someone, do you have pain, they may not be able to express it in that way. But if you say, do you feel stiffness? Are you achy? Do you have throbbing or something like that, might help an individual express pain in different words that might be more significant. So once we have found pain, once we have assessed pain as far as whether it is mild, moderate, or severe using one of the pain assessment scales, we then have to move to the actual selection of a pain medication. We recognize that most of us in the room at this training session today are not prescribers ourselves, but we have to recognize the team approach that we have and that we may eventually have the ability to influence some of the prescribing. In fact, one of the things is through maybe this team approach, we might then be able to establish some certain standards of care at our own facilities of what is acceptable and what we consider non-acceptable pain therapy, and in that way guide our best practices towards what we would like to see and what the regulatories who are evaluating our work would like to see also. Once this pain is found, then we then start putting together a comprehensive pain management program using that team approach that we discussed. We recognize that most of us viewing this tape, and certainly not the one talking on it, is a prescriber, but we do have influence over the individuals who do write prescriptions and put together the actual orders in the facilities where we work. I'd like to think that we, through this team approach, could establish our own standard of care of what we consider to be appropriate therapy and hopefully reduce the use of inappropriate therapies over time so that everybody benefits from our team approach. The selection of pain therapy, again, is based on the type and the severity of the pain the individual's having. We also look at this kind of total composite of the pain that we're having. Is it just simply looking at the symptoms of pain themselves, or can we focus in on the actual changes in behaviors, the changes in activity levels, and maybe the final things that happen with everything else that's going on. We should recognize the benefit of non-drug therapies, things like heat and cold therapy, certainly the benefits of exercise and getting up and moving around. Any of us that has any amount of arthritis can certainly recognize how stiff we are in the morning when we get up, but how things kind of loosen up as we move ahead. This is certainly important when we're looking at individuals who may be requiring wheelchairs during the day, and the idea that they do need to get up and move around and get out of that chair intermittently to reduce some of that stiffness, and certainly those individuals confined to bed to making sure that they're not lying in one position. That certainly increases the risk of pressure ulcers, but also will increase the pain that they're having from the stiffness in their joints. Finally, we move to our pharmacologic options, recognizing the broad expanse of therapies that we have available to us. Therapies that are basically very low in potency, but also carry along with that a low risk to the patients and a high availability to us as far as getting that in and using it. And then we progress on to those medications that are much more potent, but have a lot more controls to them and add a lot of risk to the patients that we're treating. And finally, we certainly want to make sure that we recognize that we use the patient's goals of care, or the patient's caregiver's goals that they have. We certainly can take away all pain, but in doing so we might add increased risk of side effects, drug interactions, and a decreased level of activity for the individual. So we may be more targeting towards and selecting therapies that will provide the maximum comfort, but at the lowest risk to those patients that we're caring for. So in moving on and looking at the medications themselves, we recognize that we have medications that are very beneficial for mild pain, those that are better for moderate pain, and then those that we use for individuals in severe pain. Recognizing as we move up the scale, again, we're increasing the activity of the drug, but also some of the risks, and also sometimes impacting the availability of those medications as we need them. When we look at these individual classes of medications, we must recognize that even though they are on the lower end of that scale, those mild pain medications do carry risks of themselves. They may be considered non-prescription products, aspirin, acetaminophen, and our non-steroidal agents like ibuprofen, but they do carry risks in and of themselves, especially in an older population. Medications like aspirin, of course, will increase the risk of spontaneous bleeding for falls. Something like acetaminophen, although it's really very safe when used in normal doses, if we use excessive doses, especially when we add hidden acetaminophen in cough and cold preparations or in our combination opioid acetaminophen products, once you then get beyond a certain point, it does add excessive risks as far as hepatic damage. Now, what dose should we be using is still up in the air when you look at the literature. The FDA is still listing over-the-counter over-the-counter acetaminophen products, still using that upper threshold of 4,000 milligrams or 4 grams a day is what's still out in the labeling. But when you look at an older population, experts generally suggest maybe reducing that upper level to something like 2,600 milligrams or 3,000 milligrams. Now, that's the equivalent of 8 regular strength acetaminophen tablets or 6 extra strength or 500 milligram acetaminophen tablets a day. So again, once you get beyond that level in an older population over 70 or 75 years of age, you are increasing the risk of hepatic damage. And finally, with the non-steroidal agents, which are quite often used for what we consider bone pain or joint pain, do have excessive risk in the elderly and sometimes are considered on the Beers list as inappropriate when used scheduled because of the risk of cardiovascular side effects such as swelling and increased blood pressure, the effects on the gastrointestinal system, the increased risk of GI bleeding, and things like that. So again, for intermittent use, for mild pain might be appropriate, but in an elderly individual, we certainly wouldn't want to see constant dosing, especially at high levels that sometimes we see when individuals come in. When we consider the risk of using opioid medications, which tend to be our mainstay in moderate to severe pain, we've got to recognize that they have broad risk that can be broken down into several of our different systems. They certainly have effects on the central nervous system where they cause increased somnolence, and in some individuals may dramatically increase the risk of falls, which of course is then going to affect the quality of life of our individuals. They also have effects on the gastrointestinal and the genitourinary system, where they can be very potent constipating medications. And we certainly want to make sure that any pain regimen that we put together anticipates this constipation. And it's one of those things that we'll talk about in a later part of the presentation. General urinary effects may include urinary retention because they are prominent anticholinergic medications. So again, an individual may have urinary retention, which in and of itself may be an additional cause for pain and changes in their well-being. And finally, they do have some cardiovascular and respiratory effects. As far as cardiovascular effects, they may reduce blood pressure, which in turn may cause increased risk of falls and increased somnolence in the individual, just a feeling of not feeling well. And the respiratory suppression effects, which we all worry about with opioid medications, is a relatively rare effect when you're looking and using oral medications, but it's something that you certainly want to be aware of in an individual who is naive to opioids. So when they first start out therapy, and especially any time that you start increasing the dose dramatically on these medications. But again, these risks must be anticipated as we use these medications. One of the things that we also must recognize is the risk of adding or using these medications with other medications. The acetaminophen content of hidden sources that we mentioned before from cough and cold preparations, and certainly as we escalate doses of those combination products with acetaminophen already in them, we've got to recognize that as you have a scheduled combination product and then add any as needed medications, even as simple as needed acetaminophen on top of it, may tip us over the edge as far as those upper level doses that we want to use. We also have to recognize the effect of multiple medications that have CNS activity. So individuals who are already on antidepressants, antipsychotics, anti-dementia drugs, sedative hypnotics to help them sleep or to calm them down, the pain medications will add to that central nervous system depression and increase the somnolence we see in these individuals and affect their activity levels. Of special concern are some drug-drug interactions that I especially want individuals to watch out for. When we add tramadol, oxycodone, or some of the other opioids to an SSRI, or a selective serotonin reuptake inhibitor antidepressant, does increase the risk of something called serotonin syndrome, which has been described everything from a flu-like feeling to causing seizures, coma, and death. So we certainly don't want to induce that kind of a serious adverse reaction simply by adding one of these medications, but it does happen, and we do have to kind of watch out for that. We also have to consider some of the adjunct medications that are added, especially with neuropathies or neuropathic pains. Medications like tricyclic antidepressants are especially troublesome in the elderly population because of the somnolence and anticholinergic side effects. Medications like the benzodiazepines, we certainly recognize how long-acting benzodiazepines like diazepam or Valium, that kind of drug, also cause effects, and also muscle relaxants like cyclobenzaprine, Flexeril, which is commonly used but shouldn't be in an elderly individual because of the other side effects. And then finally, some other drugs, cannabinoids, Marinol, that's sometimes used for appetite stimulation, may actually cause CNS depression when added with these opioid medications. So again, we have to look at the total medication list of individuals. And then finally, there are some opioid medications which certainly are recommended to be avoided in the elderly. These include things like meperidine, propoxyphene, although it's removed from the marketplace, it is still out there in medicine cabinets out there, so we want to make sure that we're not using that inappropriately. Codeine, which is a drug that's commonly used in certain practices. Most often where I see it right now is individuals who return from the dentist office with a Tylenol with codeine order, recognizing that the codeine has to be activated by the liver to its active form. that activation is reduced in the elderly, and it simply is a very constipating opioid medication. So again, it's one that we best not use if we certainly can. And then finally, a couple of other drugs, pentazocine and butorphanol, are medications that are recommended not to be used in the elderly. So again, as we look at our pain management programs, we might be able to influence our prescribers to stay away from those medications. Finally, one other area of risk I wanted to mention today is the risk at transitions. It's probably the most risky time an individual has especially related to pain medications, but really related to all the care that's given. We oftentimes, when we think transitions, we're always thinking hospital to maybe a skilled nursing facility or a long-term care facility, but transitions should be considered anytime an individual sees another prescriber, or when they move from one area of the facility to the other area of the facility, if you have that kind of variation in the care levels given at your facility. Each one of those have to be considered a transition, because that's where changes in therapy happen that don't necessarily recognize everything that's happened before or the background and history of that individual. One of the riskiest transitions I see is when an individual goes out of the facility to see another specialist. And that's when we see inappropriate medications coming back or duplicative medications. We had one case where we saw an individual who had a PRN order, an as-needed order, for 4 different opioids because they had seen 2 different dentists. They had also seen another physician, and each one came back with just a slight order difference from the opioid PRN that they already had, and resulted in basically 4 quantities of opioids in the med cart that none of them were being used, and the staff had to count them 3 times a day. And we know how that impacts the time it takes for staff use. So again, we have to recognize this whole idea of the medication history and the importance of just simply sending an updated medication list with the patient every time they see an outside practitioner might avoid this, and that might become your standard of care, where we just have one as-needed opioid per patient that we have as needed. And then finally, one of the things is at these transitions, that's a natural place to kind of step back and assess the situation. That it's an opportunity for us to, again, maybe optimize the therapy that is out there. We then can assess the patient and the level of care that they're needing, the level of pain that they have, certainly. We can assess the adjuncts that are being used or not being used appropriately at that time. And then finally can do a thorough medication therapy assessment that hopefully you can work with your pharmacist team, both the provider pharmacy and your consultant pharmacist and your prescribers, to make sure that we can get rid of any unnecessary medications that we may be using. One of the things we should recognize as we're implementing our team approach and this composite therapy for individuals with pain is the escalation of therapy, or the prescribing cascades that sometimes go along with the simple addition of one opioid or other pain medication. Sometimes these cascades may be the escalation of dosing that's necessary, as we start with an agent generally used for mild pain and then work our way up the scale to the medications that are used for severe pain. And again, recognizing that sometimes those mild pain analgesics or those mild analgesics are left on the regimen, whether appropriately or not, and so we have to kind of watch out for those. The other things is the addition of other medications, sometimes to treat the adverse effects of the first medication that we add. One of the most common cascades that we see is the implementation of a laxative program for an individual who has initiated an opioid medication. One of the physicians I work with uses the term that you can't just have mush, you've got to push the mush. So the simple addition of just a stool softener may not be appropriate, especially when I see orders for stool softeners on a PRN basis, recognizing they take 2 or 3 days to really come to effect. And if you've constipated, waiting 2 or 3 days for something to work is just way too long. So again, the addition of a stimulant laxative is appropriate for individuals who are on consistent opioid therapies, and something that should be considered. Of course, you want to look at the patient's past history. If it's an individual who has never had constipation and you add a stimulant laxative and cause diarrhea, you'll have an angry staff after you with that. So again, you certainly have to evaluate the therapy once added, but that's kind of a cascade that goes along. Some of the other negative cascades that may go along with opioid therapy may be related to things such as individuals who then have an adverse reaction to the medication, and then we start seeing medications added and added and added. an individual who has started on a laxative program and then has some diarrhea, where we then see intermittent using of antidiarrheals, then laxatives, then antidiarrheals. So again, we've got to really evaluate the whole therapy in those individuals. So finally, one of the other risks with opioid medications are some of our unanticipated adverse reactions that we see. Some individuals may develop delirium because of the anticholinergic side effects associated with using opioids. So again, that's certainly something we want to watch out for. We also have to recognize that delirium is also associated with untreated pain. There have been some good clinical studies done in individuals after orthopedic surgery that have shown that individuals who have untreated pain have a higher risk of delirium itself too. So that increase in behaviors or other side effects that we might be seeing might actually be indications that we're not using enough pain medication. So you have to look at that also. We also then recognize that some individuals may develop some agitation, some aggression, some things like that, that may be a indication of a paradoxical reaction to these opioids themselves. Again, may be related to the anticholinergic side effects of these medications. Some individuals develop an allergy to these medications. Some of them are quite known of causing itching and rashes, things like that. And then some individuals just simply are intolerant and may benefit from moving to a different opioid medication. And finally, some individuals, especially at high doses, may actually be experiencing a hyperalgesia, or basically increased pain, because they react differently to these opioids. And that is something that it's rare, but it actually may be found. And what you find is somebody increasing dose, and the pain gets worse and worse the higher you go on the dose. So something to watch out for. So I've included a slide, kind of an overview of some of the risks associated with delirium that you might want to look at and use in your practice, recognizing that delirium is associated with medication use, especially those medications that are high in anticholinergic side effects, but also things like an individual not having their eyeglasses or their hearing aids in. It may be individuals who are not eating well, individuals with constipation or with urinary retention, individuals with untreated pain. So again, delirium is caused by many different medical and medication causes, but it's something that will certainly complicate therapy. We know in hospitals it doubles the length of stay, it increases the risk of mortality, so it's something we should all be watching out for, and it is associated with the use of opioid medications. One of the things that we should recognize is that we can build our standard of care in our own facility by looking at a systems approach of how we order, how we use, and how we monitor the use of opioid medications and other pain medications. This starts with simply the orders itself, recognizing the difference between 3 times a day dosing versus Q8 dosing, if that's really what the prescriber wants. And maybe recognizing that if you get an order for every 4 hours, that may impact your nurse's abilities to give that medication through the night, especially if you have differing staffing levels depending on the type of facility you're working at. Especially for staff, I want to encourage you to document the outcomes when you're using as needed medications. In one of the facilities I worked at, we did a quality assurance audit that showed that when you looked at the medications that were checked out from the controlled substances record book, that's that book where we have to count 3 times a day to make sure that we've got the medication in the cart that's supposed to be there. What we found is about half the doses that were checked out were not appropriately documented on the written PRN sheet or on the outcome sheet, where you're supposed to document why the medication was used and then the response to that. So again, recognizing that the physicians or the prescribers, when looking at how many as-needed medications were needed, if they're thinking about escalating to a higher level of pain management, they're going to be looking at that PRN record. So it really must accurately reflect how much of that medication's been used. They will also be looking at how many sedative medications, for example, maybe an as-needed lorazepam or benzodiazepine order that's being used for agitation, recognizing that agitation itself may be a sign of pain. So again, those records must really accurately reflect that, as should the nurse's notes. If someone is noticing an increased level of agitation, anxiety, pacing, or other unwanted behaviors, that really should be documented in the nursing notes so that the prescribers, when they review the records, can see that something that may indicate pain is there, and then we could reduce those unwanted behaviors simply by maybe escalating or optimizing our pain medications, looking at that. So again, it all goes together. And you've got to recognize and take that responsibility that if you've noticed something, you've got to make sure that that is then communicated on to the prescribers and other parts of the team involved in the care of that patient. You just simply can't assume someone else will say something. It's your responsibility. And then finally, although it could be a whole nother 3-day seminar itself, is we should all then recognize our responsibility of watching out for medication diversions in these days. Certain medications, the ordering requirements have changed because of diversion that we're seeing out there, which is simply increasing the time it takes to get these medications to patients. So again, we should recognize that. And as administrators, as pharmacists, it's those issues that simply may complicate our own jobs if we're not diligent about that, and should watch out for that. As we implement that systems approach, as we optimize, I guess, the standards of care for using pain management medications in our own facilities, we do have to recognize some of the other systems approaches that must be necessary. These include everything from how we order and anticipating the orders of medications, recognizing that many of our clients, our residents, must use mail order for their medications because of reimbursement issues and things like that, which absolutely means we have to anticipate the use of that medication beforehand and not leave one of our residents hanging in pain because we're waiting for a medication to arrive that day, either from our regular pharmacy or from a mail order if that's where they have to get their medications. We also have to recognize the care that's necessary in handling some of the transdermal medication products that we have. Fentanyl is one that immediately comes to mind, where that product still has that very potent analgesic medication in there if it would happen to get in the wrong hands or potentially be diverted to another use. And then finally, we have to then look at how we document the use of our medications and the controls that we must have in place. Finally, as we put together our system, we've got to recognize that all of what we do in managing the use of these medications to control the pain is then reflected as we look at our quality indicators, which pain control is one of the major quality indicators that we have now. There are indicators related to the residents and the patients that we're caring for, especially at times what comes to mind at end of life, where we're trying to maximize the comfort of this individual and still leave them with a level of activity that is within their goals and plans that they have for themselves at that time in their life. Where we want to use appropriate pain management to relieve the pain and give them the comfort they seek, but yet leave them active enough and cognitively intact so that their families might still be able to interact with them at this very important time. And that may be a crucial time when you then implement and individualize each person's therapy at that point. We then have to make sure that we're doing appropriate assessment during that time period and documenting level of control, and especially documenting the control of pain, so that we do show that through our efforts we are then providing comfort to these individuals, not at the expense of excessive adverse reactions, but actually managing their pain in an appropriate way to maximize their level of activity. That regular assessment where we anticipate, identify, quantify, and then manage and treat that pain is appropriate, showing that the individual's pain level is lower after we implement therapy and after we implement both non-pharmacologic and pharmacologic therapy. Part of this system is our staff education and documenting that our staff that we entrust the care to do understand and recognize and can demonstrate that they are living up to the standards of care we're establishing through our entire program. That they understand the appropriate use of medications, especially when we're talking as needed medications, and how the entire regimen gets folded together with both non-drug and drug therapy, and then anticipating and documenting adverse reactions, constipation, and then implementing that appropriate laxative program if necessary for that patient. Finally, we want to make sure that our staff are documenting the outcomes, showing through the written record whether written or electronic, that the patient is actually better under control of pain, and that all our efforts are being used to maximize this therapy and maximize their level of activity. And finally, as a facility and as individual practitioners and professionals within that facility, that we are developing, documenting, using, and then reporting results for the program itself, so that we can show, whether to regulators, whether to patients and families, or just to ourselves, that we are actually doing our jobs, holding up to our responsibilities, and using these medications to the best benefit to their patients. That is our ultimate goal with our program. So finally, some of the things that we look at. So as we look at facility indicators, as we are looking at managing systems and optimizing care for individuals, we want to make sure that we're demonstrating that we're appropriately using these potent analgesics for the benefit of the patients that we're caring for, that we're appropriately implementing and using and monitoring bowel regimens for individuals because of the potent constipation that does show up with these opioid medications, that we're monitoring and reporting adverse events so that prescribers, when they come in intermittently and review our records, that the adverse effect is appropriately documented there so that the appropriate decisions and changes can be implemented for the benefits of the patients we're caring for. That we're investigating some of the complicating issues, things like depression and reduced activity level that may be either a sign of pain itself or a sign of too aggressive therapy and some of the adverse effects that may be seen. That the individuals are not developing delirium or increased agitation because of either untreated pain or because of excessive therapy with medications that have their own risks in and of themselves. And then finally, that we're documenting an appropriate availability of our plan of care and the pain medications so that the individuals have the medications that they need, that the orders are brought in and available to the patients immediately upon admissions, that someone is not waiting in pain 4, 5, 6, 12 hours for that first prescription to arrive because we didn't anticipate the needs of that patient on admission, or did not anticipate the need for a refill at a time when the patient could certainly use that medication. One of the measures that could be used just simply is then on a monthly basis reporting the number of stat fills or refills of a pain medication might be an indication of our staff's compliance to the needs of the patients here. Again, a nice QA program that could be implemented and could be used on a regular basis to monitor our pain control and could demonstrate to the regulators that we are using pain medications appropriately, that we're reducing the number of controlled meds that have to be counted 3 times a day by our staff because we've left unnecessary and unused opioids into that cart, which again increases risk if used inappropriately for the patient, could increase risk if diverted by staff illegally. And then finally, we want to reduce the cost and the waste from these unnecessary medications. Again, looking and making sure that the medication list is sent with a patient when they go to see the dentist or an outside practitioner so they don't come back with an unnecessary duplicative opioid medication that might be sitting in the cart for 3 or 6 months unused. So finally, some of the indicators we could be used. We have indicators that could show an increased number if our system is working appropriately. We would see an increased number of residents who are achieving pain control goals as established at their care planning. We could see an increased number of residents with improved functioning and with improved quality of life. We could see an increased number of residents that are recovering and essentially leaving the facility, I'll use the term on time, as anticipated with an admission care plan to a skilled unit, showing again by proper use of pain medications they are able to comply and complete their therapy in a prescribed manner. And then finally, increasing the number of residents receiving appropriate adjunct therapies and showing that we're using those non-drug therapies in addition to the medications. Some of the quality measures we could use should be decreased. We should see a decrease in the number of inappropriate orders that have to then be clarified after the fact. We could see a decrease in the number of PRN analgesics that are used, indicating that the individual isn't receiving enough scheduled medication to control their pain throughout the day. We should see the decreased number of residents with constipation or impaction, or decrease the number of emergency laxative orders and PRN orders that are being used. So again, if an individual is seeing an increased number per month of PRN, milk of magnesia, or enemas or something like that, that's an indication they're not on a good regimen for laxation. We should see a decreased number of the patients that are reporting uncontrolled pain. That's certainly a link to quality of life there. And hopefully see a decrease in the number of patients that are having symptoms of the behavioral and psychiatric symptoms of dementia, or some of those dementia signs, or the sundowning that is sometimes reported. Again, recognizing that agitation and behaviors could be linked to either uncontrolled pain or excessive use of medications and a side effect. And then finally, we should see a reduced number of stat refills that are needed because we've not anticipated the need for medications. Again, just some ideas of some quality assurance and performance measures you could use to show the adequacy of your system's approach to treating pain in your facility. So finally, in summary, we've talked about a lot of things we probably already knew, but maybe needed a quick reminder. I hope that you've gathered at least one idea of something you might be able to implement in your facility to improve both your performance measures, but ultimately the quality of life of the individuals you're caring for. We've talked about implementing a team report approach where all of us have responsibility, where we don't assume someone else is going to report something that we've noticed. We finally hopefully have identified some of the points of risk, where we both identify and anticipate that risk in individuals and hopefully make decisions to reduce that risk. We know that transitions of care, transitions between facilities, transitions between areas within a given facility, transitions between practitioners are points where we have to take a very close look at changes in orders to make sure that the individual is not put at risk. We also have to recognize and watch for therapy escalations and de-escalations, recognizing that sometimes as an individual is moved from a hospital where they've been on a patient-controlled pump, and then within 6 hours moved to an oral medication and then reduced in dosage when they then go out to the facility, maybe a true risk of untreated pain. We've got to watch out for that. We also have to kind of watch out for escalations where the individual may be at increased risk of some of the CNS side effects or other adverse effects of the medications. And then finally, we must be acutely aware of changes in the patient's condition that may signal untreated pain or excessive use of medications that now they're suffering for an adverse effect. That is where we then implement and relate our performance measures that we're talking about, and eventually leading to an increased quality of life for those individuals who are under our care. I hope this has been beneficial to you. I wish you well and hope that you're able to put in a new standard of care in your own facility. Thank you.